What do you think, Lorraine? Shall I go ahead and get started?
Yeah, I would go ahead and get started. I think some people
Yeah,
might be joining late because we're so busy.
it's no problem. I'll get started. It's 10:05. I want to make sure we stay on time. I again appreciate being invited to present this. This is the second, I know it says March. That's when I first presented this talk. Happy to present this again for nursing staff. Again, I'm Santosh Pandipati. I'm the maternal fetal medicine director at O'Connor Hospital, and I've been asked to present on preeclampsia and hypertensive complications of pregnancy. I really view this as an opportunity to speak about the red flags that we have that impact maternal morbidity and mortality. And it's important to understand that preeclampsia is a major contributor to maternal mortality and morbidity. And I'll go through some of that with you. I want to go through the management of preeclampsia. I want to go through the physiology or pathophysiology of preeclampsia. Hopefully have plenty of time at the end for some Q&A. So the objectives are pretty straightforward. We need to understand how preeclampsia contributes to pregnancy-related mortality rates in the US and California. We should make sure we understand the ACOG diagnostic criteria for preeclampsia. We want to make sure that we understand how to treat acute severe hypertension. We want to understand how we manage preeclampsia that has severe features. We need to make sure that we understand when we deliver patients with preeclampsia. And we also need to understand what preeclampsia means for the future health of the mother. As nurses and nursing staff, you are the linchpin really for a lot of patient education and clarification of the care plan between the providers and the patients and their families. And so I think the more that we work as a team, the better served the patients will be, and the better outcomes that we will achieve together. So my only disclosures are that some of these slides I've adopted from the California Maternal Quality Care Collaborative. There are no personal conflicts of interest. And I do think somebody may not be on mute. I'm hearing a lot of background noise. So if I could just ask everyone to just mute on their end, then we can avoid the background noise. Thank you so much. So before we get lost in the trees, and we can very easily jump into, oh, this is how we treat severe hypertension and so forth, I want to take a step back and just look at the big picture. Let's look at the forest in totality and then dive in. How are we going to get through this forest, and what are the ways to best navigate through this territory? So I think we all take it for granted. We're talking about sexual reproduction, but the reality is there are other ways to reproduce in the animal kingdom. There's asexual and there's sexual. And within the sexual forms of reproduction, you can lay eggs or you can give birth to live young. And as mammals, human beings, of course, being among mammals, the most primitive actually lay eggs. We typically think of mammals as always having live born, but that isn't the case. Marsupials were kind of the next evolutionary step. They have a very short gestational period. Their young are born live, but pretty immature, so they continue to develop in a marsupial pouch. But really, it's the evolution of placentas and the placental mammals that really kind of accelerated things to the next step. This is where young are born live and in a more advanced state because they have a longer gestational period afforded to them by having a placental organ. And so placentas, of course, serve as nutrient transfer to protect against invaders such as viruses and bacteria, so immune protection, respiratory function, right? The exchange of oxygen and carbon dioxide, waste removal, so metabolic waste that the fetal kidneys are not very mature. They can't remove metabolic waste, so the placenta serves in that role. Something has to tell the mom's body, hey, you've got to support this baby that's growing inside of you. So what is that? Well, it's the placenta that's sending hormonal chemical signals, messages to the mother's body to change the maternal physiology to support pregnancy. And of course, it's also a big reservoir for fetal blood because at time of delivery, there is blood loss. So it's important to understand that acts as a reservoir. So placentation is the key to our mammalian success. But here's the problem, it doesn't work all the time. So another way to look at a fetus, and this is tongue-in-cheek, a rapidly growing, metabolically active, respiring, semi-foreign organism designed to propagate the parental genes, but whose eventual ejection from the host results in a bloody mess. And we all know this. We've all been at deliveries. So putting the tongue-in-cheek aside, in order to understand the abnormal, we first have to understand what happens normally. So I want to make sure we have a basic understanding there. And remember what the underlying task is. It's to grow another organism, meaning a baby. This requires a lot of physiologic accommodation, and it makes pregnancy inherently, frankly, a dangerous condition. We think of pregnancy as a normal, natural, healthy process, and it is in 75, 80% of cases. But there's always lingering in the background that potential for something to go wrong. And it's that potential for something to go wrong that is where we come in, right, as the clinical care team. So the placenta is the crucial organ for accomplishing the task of growing a baby. Now, I think we certainly have seen where we have been told by patients and families that this is a little too invasive, so to speak, what we do in obstetrics. And they said, well, this is a natural process. And I say, yes, it's a natural process, but it's fraught with pitfalls because the evolutionary process is not perfect, right? We're part of nature. Our solutions are encompassed in the natural order of things. And it's not wrong to intervene. In fact, it's a moral imperative to intervene when we have the ability to make a difference. So we actually have a lot of good evidence for what we recommend and what we do. And this is why I'm presenting this to you. So what do we mean by dangers of pregnancy? Well, pregnancy is actually the second leading cause of death worldwide in women ages 15 to 44. Unbelievable, right? Now, this data is a little bit old, but I haven't been able to find more updated data, but it still ranks very high. So we're talking about HIV, tuberculosis, suicide, traffic accidents, respiratory infection, all of that aside, pregnancy in and of itself increases the risk of death. So we should take this seriously. Now, how widespread of a problem is that? Well, it just depends where you are in the world. There are parts of the world where there are over 1,000 maternal deaths per 100,000 live-born children. And there are places in the world where it's almost non-existent, 2 per 100,000. They're not necessarily the richest countries or the poorest countries. What's interesting is the United States doesn't fall in the worst, and it doesn't fall in the best category. Now, when you look across the world, fortunately, maternal deaths have fallen since 1990, but maternal hypertensive disorders rank as a leading cause of maternal death. The US, unfortunately, has had the opposite, where pregnancy mortality has been on the rise. And it's been rising as shown by the CDC data, where actually in the late 80s, it was 9 deaths per 100,000, and now it's over 16 deaths per 100,000. So the sad fact is that 55 nations in the world have a lower maternal mortality rate than the United States. This is according to 2017 World Bank data. So we are not exceptional in terms of the quality of care that we are providing for patients who are pregnant in terms of avoiding mortality. And in fact, here you can see compared to other high-income nations in the world, the US is actually having a rising maternal mortality rate, whereas all the other nations are improving across the board. When you look at causes of mortality in pregnancy, you can see that hemorrhage and hypertensive disorders account collectively for about 20% of causes. And those are our focus in the CMQCC and at the hospital level, because those are things that we can try to address and actually make a meaningful difference in terms of reducing incidence. When you look between populations, there is clear inequity between populations, such that, for example, the non-Hispanic Black population has nearly 40 deaths maternal deaths per 100,000 live births as compared to the other populations that have about a third of that. So we have a long way to go. The good news is we live in California, and the good news is that in California, we've had a declining maternal mortality rate, and we have bucked the trend that we have seen in the United States. So if you look, especially since about 2007, 2008 to now, there has been overall a steady decrease in maternal mortality rate, in large part due to the efforts that we have all made collectively in the state to raise awareness and to intervene aggressively for mothers who are developing hypertensive complications. So we're fortunate, right? So when you look at where California stacks up to other states, you can see that our maternal mortality rate ranks amongst the best states. And there are states that have a threefold higher maternal mortality rate compared to California. So the good news is California is fairly exceptional in this manner, but there are states better than California. Massachusetts, for example, has 5.6 maternal mortality deaths, per 100,000. Now, when you look worldwide, preeclampsia affects about 5 to 8% of all pregnancies. It's among the top 3 causes of maternal morbidity and mortality. And about 10 to 15% of maternal deaths are directly attributed to preeclampsia or eclampsia. In the United States, 16% of maternal deaths are due to preeclampsia. So pretty comparable to the world, maybe a bit higher. And we also have, of course, babies that die as a result of preeclampsia because of placental abruption or prematurity or secondary complications. And unfortunately, the preeclampsia incidence has been rising in the United States over the last 20 years by about 25%. So we're headed in the wrong direction. And in fact, when you look at hypertensive disorders of pregnancy collectively, and you look at the incidence per 10,000 deliveries, there is a rising rate of hypertensive disorders in the United States since the 1990s. And when you look at chronic hypertension in and of itself, it's already a risk factor for development of preeclampsia, and that too has been rising. When you look at specific causes of death in California, the top 5 from 2002 to 2004, you can see that preeclampsia caused 17% of pregnancy-related deaths in the state of California. These were 25 patients specifically. So this is equivalent to a mortality rate of 1.6 deaths per 100,000 live births due to preeclampsia or eclampsia in the state of California. Okay, so when you look at these 25 people, out of 145 mothers who died, 25 died because of preeclampsia, eclampsia. Well, the amazing thing is that was the diagnosis on the chart as the cause of death. But when you look at the 145 women total who died, over half of these women had had hypertension as a comorbidity. So 34% had an inpatient diagnosis of hypertension, 39% had any diagnosis of hypertension, whether inpatient, prenatal, or pre-existing. So half of the pregnancies, half of the mothers who died from in pregnancy in this 2002 to 2004 period of time had hypertension as a contributing cause. And unfortunately, maternal hypertension has been rising in California, not just in the United States, but in California as well. And this is noted at time of hospitalization for labor and delivery. So how successful could we be? Okay, they're coming to us more likely to be hypertensive. Can we really make a difference? And when you look at those 145 mothers who died from pregnancy, and you look at specifically preeclampsia and hemorrhage, you can see when you go back and you do the chart reviews, you can see for preeclampsia, eclampsia, about half the time, there actually would have been a very strong chance of improving the outcome, in other words, avoiding the death. And at least in half of the cases, some ability, had there been earlier recognition of the disease, to have made a difference. Now, so essentially 100% of the maternal deaths from preeclampsia or eclampsia could have had some difference in outcome or a completely different outcome had there been better recognition of the disease process. When you look at hemorrhage, about 70%, I'm just rounding, there was a strong indication that we could have made a difference. And in about 25%, some indication that we could have helped improve the outcome. So 95% of those cases, we could have made a huge difference, right? So this is why it matters to be targeting hemorrhage and preeclampsia, especially because we have a chance to really make a big difference in these cases. Now, why are they dying? How is preeclampsia really causing death? Well, it's causing death because of stroke in about 2/3 of patients. So the reason people die is because they have a hemorrhagic stroke from the severe hypertension that they're dealing with. And in fact, when you look at across the US at the CDC review of 14 years of data, over 4,000 maternal deaths, about 20% of those maternal deaths were from preeclampsia. And when you look among those, 90% of those deaths were from a stroke, a cerebrovascular accident, and it was a hemorrhagic stroke. So this is very interesting, right? Because stroke from hypertension can be avoided. Now, how do we compare in California versus a leading nation in the world that has dramatically reduced mortality rates related to preeclampsia? Well, when you compare against the United Kingdom and you look at strokes, for example, in California, essentially 1 out of 100,000 live births, mothers die from hemorrhagic stroke. And so when you look at the UK, it's about half of that, 0.47, okay? So when you look at other causes of death, in addition to stroke, respiratory, pulmonary, hepatic, overall, the California mortality rate for preeclampsia is 1.6 per 100,000. That's more than twice the rate in the United Kingdom. And it's largely explained because of the difference in terms of avoiding strokes. So we have an ability to make a difference. The UK is a great example where we can reduce maternal mortality. The key clinical pearl is that you have to control the blood pressure. That's the optimal intervention to prevent deaths due to stroke in women with preeclampsia. Over the last decade, the United Kingdom has focused their quality efforts on aggressive treatment of both systolic and diastolic hypertension. And this has led to a measurable reduction in deaths. So when you see that severe range blood pressure, please take it seriously. Please don't blow it off, because this is a mother whose brain is not used to these blood pressures. This isn't like a 90-year-old who's had very high blood pressures for 40 years and whose blood vessels have hardened and actually have a harder time stroking out than the mother who's in her 20s or 30s who's never had blood pressures this high, whose blood vessels have no capacity to deal with such high blood pressures. Now, we are talking about deaths and maybe some morbidity, but what we really are not understanding by focusing just on deaths is that this is the tip of an iceberg. There is a lot of suffering and a lot of injury that happens even if you don't die. And so it's estimated that, yes, in 2007, there were 8 preeclampsia mortalities or deaths, but there was 40 to 50 times higher near misses in terms of ICU admissions and prolonged hospitalizations, and 400 to 500 times of other morbidity where it's just a prolonged hospitalization that increases their risk for other complications. So it's very much a big problem, more than just in terms of maternal death. And when you look at what were the factors that were associated with maternal morbidity in both developing and developed countries, it's actually things that we can try to address. Lack of prenatal care, lack of access to hospital care, lack of well-trained staff and personnel, lack of proper resources. The magnitude may differ between high-income and low-income nations, but the quality issues are similar, okay? So when you look at, again, going back to those 25 preeclampsia deaths, and we talked about how we could have made a difference, how so? Well, when you look at preeclampsia, there was a delay in diagnosis in 90% of those patients. So had we identified the developing pathology earlier and treated it more aggressively, we might have been able to have made a big difference. And unfortunately, in 80% of those cases, we used ineffective treatment. We were not aggressive enough in trying to reduce their blood pressures to try and keep their blood pressures under control. This is very, very valuable information to say, you know what? This isn't pie in the sky thinking. We can actually make a difference here. Now, look at how that stacks against the overall total population of maternal deaths. In about half of those mothers, there was a delay in diagnosis, and in about 40% ineffective treatment. This includes all the other, causes of death, amniotic fluid embolism and pulmonary embolism and all those things. So in preeclampsia in particular, we can make a huge impact and a huge difference. So now let's start looking at the details. Let's look at the trees, okay? We all should know these definitions, so I'm not going to belabor the point. Preeclampsia is new onset hypertension and either proteinuria or some form of end organ dysfunction at 20 weeks or later, okay, in mothers who have no history of hypertension. The severe form means either you have severe hypertension or you have end organ disease. Eclampsia, of course, is the grand mal seizures associated with this condition. And it's in the absence of other neurologic conditions. And then, of course, we've got this condition called HELP, which is hemolysis, elevated liver enzymes, and low platelets. This overlaps with severe preeclampsia, but isn't exactly the same. Now, what's gestational hypertension? This is high blood pressure without proteinuria or other signs or symptoms of preeclampsia at 20 weeks or later, and it resolves by 12 weeks postpartum. Chronic hypertension, on the other hand, this is ACOG definition, and we'll talk about the difference between ACOG and the American Heart Association. But ACOG still defines chronic hypertension as 140 millimeters mercury systolic or 90 millimeters diastolic or higher on two separate occasions that either precedes pregnancy or is noted before 20 weeks GA and persists longer than 12 weeks postpartum. What is the wrinkle in this? Pretty much all the perinatologists in the community have converted over to the diagnosis of chronic hypertension in line with the American Heart Association and the American College of Cardiology. Stage 1 hypertension in the primary care realm is actually defined as systolic blood pressures of 130 or higher and diastolic blood pressures of 80 or higher. So if I'm seeing a mother at 14 weeks and she has a 135 over 85, and I see her back at 16 weeks and she's 132 over 81, she's got chronic hypertension. Okay, I'm not waiting for ACOG. This is somebody who needs to be on low dose aspirin and needs to be monitored like somebody who has chronic hypertension. And we'll get to that. Now, preeclampsia that's superimposed is new onset proteinuria or end organ dysfunction at 20 weeks or later in women who already have chronic hypertension. So we've talked about some of this epidemiology, about 5% of pregnancies worldwide, 3.5% of pregnancies in the US. There's late onset, which is the majority of cases, so 34 weeks or later, that's 90% of cases. Early onset, which is less than 34 weeks, about 10%. Along with eclampsia, this is responsible for 10 to 15% of direct maternal deaths worldwide. Excuse me. In the US, this ranks, of course, among the top causes of maternal death. Risk factors, well, if you have a prior history of preeclampsia, and especially if you had mid-trimester, so the earlier onset, if you had prior non-severe preeclampsia, less of a risk, but still an increased risk. And interestingly, if you had an uneventful first pregnancy, that was actually kind of a protective factor. There's a very low chance for you to get preeclampsia, but not zero in your second pregnancy. If it's your first pregnancy, if you have a family history and a first degree relative, so you had a mother or a sister who developed preeclampsia, that's a higher risk. Other risk factors, pre-existing medical conditions like pregestational diabetes. If what we used to call borderline blood pressure, now chronic hypertension, right? So blood pressure 130 over 80 or higher at the first prenatal visit. If you have the higher your diastolic, the higher the risk. If you have antiphospholipid antibodies, you don't have to be obese. You can simply be overweight and have a higher risk. And if you have chronic renal disease, okay, so twins, triplets, advanced maternal age, all are risk factors. So what's actually happening here in preeclampsia? Well, and gestational hypertension, what's happening is you have abnormal development of placental blood vessels that is seen weeks to months before the clinical onset of disease. you underperfuse this placenta and you have placental hypoxia and ischemia. And what happens is these placentas, remember I told you they release various chemical signals or hormones to tell the mother's body how to adapt to the pregnancy? Well, you get this pathologic release of anti-angiogenic factors such as sFlt1 and other molecules that then maladapt the mother's system. If you look at the top picture, that's the normal situation where placental tissue is on the left, myometrial tissue is on the right. So the mother's lining of her uterus is in the middle, that's the decidua, okay? So normally what happens is the placental cells on the left start marching into and invading the decidua, and they start remodeling the spiral arteries. And they make these spiral arteries patent. They epithelialize the spiral arteries. They create a high flow situation where there's very low resistance and lots of lush blood flow and exchange between the maternal and fetal circulations. What happens in preeclampsia is we don't see this remodeling. We see very stiff spiral arteries that haven't been remodeled, very restricted flow, which leads to the hypoxia situation and the abnormal release of angiogenic factors, okay? So we're working out over the last 15 years the real pathophysiology that's happening in preeclampsia. And this is happening very early. This remodeling is happening between 12 to 20 weeks. And so by the time this has already happened, you may not see the impacts for another few months down the road. So there's a widespread then maternal systemic endothelial dysfunction that leads to increased vascular permeability. That's what leads to the swelling, the edema, right? So we get swelling, third spacing of fluids. So that's why moms show up with puffy faces, puffy hands, pulmonary congestion. They get vasoconstricted. So then they're severely hypertensive because their blood vessels are constricted. You can get an activation of the coagulation system. So DIC and HELP syndrome in terms of hemolysis. And there's an inadequate plasma volume expansion. And there's a retention of response to angiotensin. So this leads to the overall syndrome that we call preeclampsia. So this diagnosis of preeclampsia is sort of elusive, right? And it doesn't actually depend on proteinuria. That has been thrown out. Yes, proteinuria helps us diagnose, but you don't have to have it to have preeclampsia. So excessive proteinuria can be diagnosed either by a urine protein creatinine ratio of 0.3 or greater, or a timed urine collection, okay? So that's important to understand that PC ratio, especially look, you're 35 weeks, mom's coming in, she's 150 over 80, 150 over 90. You're trying to get a quick understanding of does she have preeclampsia or not. You're not going to wait 12 hours or 24 hours to do a timed urine collection. You want to have a quick answer and you can do the urine protein creatinine ratio, okay? But it's also valid to do a timed urine collection. In the absence of proteinuria, new onset hypertension with any of the others, thrombocytopenia, rising creatinine, rising LFTs, pulmonary edema, visual symptoms, those also can help you diagnose preeclampsia. And severe features are pretty much any of these findings, okay, that are listed below. And again, I just went through all of those with you, okay? But it's important to understand that any of these meet the criteria for severe features. Now, once preeclampsia sets in, it's a progressive disease. And most patients will have gradual worsening, but about 1 out of 4 will experience a rapid progression over days to weeks. And you all know these sequelae: seizures, abruption, hepatic rupture, hematoma, DIC, stroke, pulmonary edema, possibly needing mechanical ventilation, fetal growth restriction, premature delivery. We often have to deliver moms early because they are so sick. The ultimate cure is delivering the placenta, and there's no way to deliver the placenta without delivering the baby. So ultimately, that's what has to be done. When you look at the latest ACOG timing guidelines, when you look at when patients should be delivered, it just depends on whether they're having chronic hypertension with exacerbation, gestational hypertension, preeclampsia with severe features or without. And so some of these situations you may have to deliver as early as 34 weeks. Now, I do want to emphasize that what's happening in the outpatient ambulatory setting may not match. It may be that a patient has shown up to her doctor's office for multiple prenatal visits, 140s over 90s, no symptoms and no protein and normal labs, but she's got gestational hypertension and she's scheduled for the induction of labor at 37 weeks, 0 days. And it may be that she shows up and on the day she shows up, she's 130 over 85 and not actually 145 over 95. It doesn't change the diagnosis. The diagnosis is made in the ambulatory setting, and it's great that she shows up with maybe a little bit lower blood pressures, but you still got to move forward and we got to get her delivered, okay? So that's for her safety, and this is level 1 randomized controlled trial evidence, okay? So very important that we do that. Now, when we talk about severe features and when do we deliver, it's a fairly complex tree. There are some, you start at the top and you observe, right, for the first 1 to 2 days, give the corticosteroids, the betamethasone if they're preterm, give magnesium sulfate for prophylaxis, give antihypertensive medications, do an ultrasound, figure out what's going on with the baby. Now, if the mom's already got eclampsia, it doesn't matter how far along she is in pregnancy, she's got to get delivered. If she's got pulmonary edema, DIC, you can't control the blood pressures. If the baby is demised, if you're pre-viable, if you've got active bleeding and a placental abruption, you can't wait. You got to just get her delivered. It doesn't matter the gestational age. Now, there are certain situations where we can wait, and we can wait long enough to get the steroids on board. And that's certainly true in that middle box. If you've got help or partial help and the mom is otherwise stable, if you've got fetal growth restriction, if you've got severe oligo, if you've got reverse diastolic flow, there are some clear pathways. Now, if you don't have any of that, then great. You just stay in-house. These are, again, severe features. So what might have been a severe, maybe she had a headache when she first came in, the headache's gone. Maybe she had severe hypertension until you got it under control, and now that's under control. Okay, keep her in-house. We try to achieve, 34 weeks, and then get her delivered once she's at 34 weeks, or deliver sooner if anything else happens that warrants an earlier delivery. So while she's in-house, you want to consult the high-risk team in terms of neonatology and maternal fetal medicine. You want to make sure anesthesia is aware, and you want to make sure she's at the right center to be able to do the care that is needed. So again, these are slides from the CMQCC that basically reiterate what I just went over. Now, if you have any of the criteria on the left, you really don't delay delivery to 34 weeks, okay? So this is, again, a reiteration of what I went through. So if you've got severe right upper quadrant pain, you've got eclampsia, you're hypoxic, you're in renal failure, okay, look, we're not gonna be sitting around waiting, okay? Now, if they stabilize, you can continue inpatient expectant management, and we're checking labs serially. We're checking vital signs frequently. We're evaluating the fetus by the fetal monitoring by ultrasound frequently. And we proceed to deliver at 34 weeks or earlier, frankly, if we have any new contraindications that develop, if there's any recurrent symptoms of severe preeclampsia, if we have recurrent severe hypertension that we can't control, if there's HELP syndrome. Now, if the mom is going into renal failure, if she's having an abruption, or if the baby's looking worse in terms of status, then we need to bail and not wait till 34 weeks. So let's talk about magnesium, because this comes up a lot, right? What is the value of magnesium? Well, magnesium is meant to prevent seizures, and NNT is a concept, statistical concept, that stands for number needed to treat. How many people need to get magnesium who have preeclampsia to prevent one seizure? We know from the MAGPIE trial, which was a large international randomized, actually beautifully designed, double-blinded, placebo-controlled trial, okay? 10,000 women. And they looked at women who had severe preeclampsia and non-severe. At the time that the MAGPIE trial was there, they weren't calling them severe features or with or without. They just called it severe or non-severe. And so you had to give 100 mothers magnesium who had mild preeclampsia to prevent one seizure, whereas you had to give magnesium for 60 mothers who had severe features to prevent one seizure. And interestingly, there was a difference in terms of where you were in the world. And in the high-income nations, there seemed to be even less of a benefit for the mild preeclamptic mothers to get magnesium. Which is why, for the most part, we focus magnesium on the severe patients. But it's not wrong to give magnesium to patients with quote unquote mild preeclampsia or preeclampsia without severe features. Now, why magnesium? It's interesting, right? We have other anti-seizure drugs, phenytoin, diazepam, so in other words, Dilantin and Valium and others. Well, it's been shown in multiple randomized controlled trials, observational studies, and meta-analyses that it's superior to all these other meds. Magnesium sulfate is working in a different way than some of these other anti-epileptics, and that's because preeclampsia causes seizures in a different way than typical seizure disorders. And it's been shown to cause about a 60% reduction in seizures, about a third reduction in abruption, 45% reduction in maternal death. So we all understand it's about a typically 4 gram loading dose, and then 1 to 3 grams, typically 2 grams an hour. Now, what we mean by a therapeutic range is not so much therapeutic as opposed to, look, this is the range you need to be in to avoid maternal toxicity. So you got to watch for that toxicity, and you continue typically through 24 hours postpartum, longer if needed based on the maternal course. Now, I want to take a pause here and look at 160 over 110 as a stop sign, a red flag. Don't ignore this, okay? It's very important, again, going back to the maternal mortality comments and avoiding stroke, that you immediately identify severe hypertension, notify the physician, initiate fetal surveillance, repeat the blood pressure within 15 minutes. And if they're persisting, you need to start immediately treating. And if they don't have an IV, you can use nifedipine. This is the ACOG management for severe hypertension if you don't have an IV, and you follow this algorithm. And this is, again, oral nifedipine, which is safe to use. Now, this is with hydralazine, and this is once you have an IV in, and this is with labetalol once you have an IV in. So there are order sets that guide you through the management of severe hypertension. Now, if you've gone through one of these meds and you're not getting anywhere, then you switch to the other medication and try the other route of treatment. So remember that in patients with severe, especially preterm preeclampsia, this is a disease that can rapidly progress to cause significant maternal morbidity or even maternal death. Postpartum, it takes a little while, but headaches often resolve quickly. Proteinuria can take several months to correct. Third space fluids need to be mobilized, and there's usually an autodiuresis that begins within a couple days. And hypertension can worsen over the first 1 to 2 weeks postpartum, but normalizes in most women by 4 weeks postpartum. And we need to verify that these labs have normalized by 6 to 8 weeks postpartum. Their LFTs, their creatinine, their platelets, et cetera, because sometimes these secondary injuries persist beyond that. So this is a very interesting postpartum real case from the CMQCC that I wanted to go over with you all. So this was a 24-year-old gravid 2-para-0 mother who had a prior early loss, who was at 39 weeks. She had an unremarkable prenatal course, GBS positive. Blood pressures were normal throughout her prenatal time period. She presented to the office with complaint of regular uterine contractions, had a cervical exam that was indicating 3-centimeter dilation, and at the routine prenatal visit, she was 142 over 95, and her urinalysis was negative for protein. So she was sent to labor and delivery appropriately for being in early labor and having gestational hypertension at minimum. And so then she had lab work. And while on L&D, her pressures were a little bit better, and her labs were all pretty much negative, but she was kept. And the blood pressures remained modestly elevated throughout the labor and postpartum stage. She was induced. She had a consistent category 1 tracing throughout until the very end. And then at the very end, she had a reassuring tracing, but then stalled out, had failure to progress on day 2 of her induction, and had a C-section. And her postpartum course was unremarkable. There was no documented complaints of headache, blurred vision, or epigastric pain. On postoperative day number 3, however, the patient suddenly complained of an acute crushing headache, rated this as a very severe level, as 8 out of 10. But the discharge orders were already written, and the patient had already been written for some pain meds. So she was administered, pain medication, hydrocodone, acetaminophen combo, and she was discharged 30 minutes later. And there was no mention of the headache and no follow-up for this headache. So she goes home, and post-op day number 4, she was telling her family, this headache's getting worse. Post-op day number 5, the headache is really bad, and now she's having visual changes. So this is worrying her family, and the family calls 911. And while they're waiting for emergency services to arrive, she has her first seizure, and the family witnesses this. And then she has multiple seizures thereafter. She's intubated in the field, and she's transported to the hospital. She started on magnesium, and she started on Ativan and Keppra as well, just for kicks, and labetalol for bringing her blood pressure down. And she's helicoptered to a tertiary center that has a neurologic ICU because she's basically having recurrent seizures. The good news is the seizures abate with treatment, and she's extubated shortly after admission, but her blood pressures remained elevated. And interestingly, they were not severely high after a few days, right? By post-op day 6 through 9, 148 over 98. Most of the blood pressures were actually 130s, and most of the diastolics were in the 80s. Her labs are all okay. The creatinine was borderline high at 0.9. Never had protein in the urine. And she had some persistent mild headache with some postural component, and anesthesia was consulted, and MRI was done that showed, fortunately, no evidence of ischemic or stroke injury. Okay, so this was an avoidable situation. Had there been earlier recognition that this headache might have been worth paying attention to in somebody who has no prior history of headaches, that it may be worth delaying her discharge for further evaluation, that if there is a suspicion for preeclampsia, that we would actually put her on magnesium and not discharge her. We could have avoided the costs to the system. We could have avoided potential injury to the patient. We could have avoided potential death, right, for this mother. So we need to pay attention, especially in the postpartum time period. This has been highlighted, and you may have heard of this being called the 4th trimester. It's a very significant time period for development of not only hypertensive complications, but mental health complications. So there is a phenomenon called late postpartum eclampsia, where, like this mother, more than 2 days following the delivery and up to 6 weeks postpartum, that you can actually get eclamptic seizures. And it accounts for about a quarter of all cases of eclampsia. The scary part about this is about 80% had no prenatal diagnosis of high blood pressure. And the magnitude of the blood pressure elevation doesn't predict whether you're going to seize or not. And the most common presenting symptom is headache, occurring in about 70% of patients who have late postpartum eclampsia. But you can have other prodromal symptoms, such as shortness of breath or blurred vision or nausea, sudden vomiting, edema, and other neurologic deficits or epigastric pain. So it's important that if you're discharging these patients who had a known diagnosis of gestational hypertension or preeclampsia, that you have early post-discharge follow-up for all of the patients. What do we mean by this? Well, the preeclampsia toolkit recommends post-discharge follow-up within 3 to 7 days if a medication was used during labor and delivery, or within 1 to 2 weeks if no medication was used. Personally, our group generally just says, you know what, just follow up with everybody within a week, because it's not going to hurt, whether they had meds to bring down their blood pressures or not. And it's just too complicated to think about the differences. So standardize it, see these patients within a week, and then just make sure they're doing okay. Now, the other important thing is postpartum patients who present to the emergency department with new onset of hypertension or preeclampsia or eclampsia need to be assessed and admitted to an OB service, not to a general medical floor where they don't understand how to manage this condition, okay? Now, it's important to understand that pregnancy-related deaths by cause and timing, that risk lasts, okay, even beyond, and there is some residual effects, for example, cardiovascular disease that persists even a year out from the pregnancy complicated by preeclampsia or hypertension. So there are some long-term residual effects that continue after the pregnancy is over. So what about women who have this complication, and what can we do to prevent? Well, a lot of this ties into the risk factors that we've talked about, right? So if you've had a prior pregnancy with preeclampsia, especially early onset, and I've went over all of these, Now, preeclampsia is associated with increased platelet turnover and increased platelet thromboxane levels. So low-dose aspirin, 81 milligrams once a day, is the mainstay of prevention for women at moderate to high risk. This is endorsed by the U.S. Preventive Service Task Force and ACOG. It reduces the recurrence risk by 25%, best to start at 12 to 16 weeks. It's possibly effective starting as late as 28 weeks, but you get more bang for your buck early on, and they just stay on it until delivery, and there's no maternal or fetal harm. It's important to understand that the mother who just had preeclampsia or gestational hypertension failed a cardiovascular stress test. Pregnancy is a stress test of the cardiovascular system, and preeclampsia is a failed stress test. It's important to understand that this is an indicator of long-term potential risk for the mother. The more severe the preeclampsia, the higher the risk for heart disease later in life for that mother. And there's twofold higher risk for heart disease as early as 5 to 15 years after that pregnancy that had the preeclampsia. Okay, the American Heart Association identifies preeclampsia, gestational hypertension, and gestational diabetes as cardiovascular risk factors that compare to obesity and cigarette smoking in their risk. Okay, so some parting thoughts. Don't underestimate the disease. Preeclampsia presents differently in different patients and can present differently from pregnancy to pregnancy. It can easily be missed, so don't be swindled by a sometimes benign appearance of the disease. Fetal growth restriction and preeclampsia are two sides of the same coin. Both human beings are connected to this placenta, and if you have a placenta misbehaving, either condition can develop. And remember, 160 over 110, it's a hypertensive emergency. By the way, it doesn't have to be 160 over 110. It could just be systolic severe hypertension or just be diastolic severe hypertension or both, okay? So I really thank you for your attention. Let's take questions. I'm gonna stop sharing my screen. And I'm happy to address any questions that people may have. And so feel free to shout out. I don't see anything in the chat box at this time. So hopefully everyone heard the presentation because I still see people on, but I wasn't sure if anybody had any clinical scenarios they wanted to discuss, if they had any confusion or doubts about any of what I had mentioned.
Hi, Dr. Pandipati, it's Lorraine. No, that was an amazing presentation as usual. It always, every time I hear the numbers and the statistics, it always just really hits me again, like how much we can do to prevent it. And I think like one of the things I keep saying over and over to the nurses is how much and how important their education is, and including those families and so forth. And I'm wondering if there's anything else we can do. One of the things that comes up for us is the headache. You know, the headache is a common with pregnant women who just delivered. It's common with women on magnesium, just common in general. And so I think that's one of the biggest things we have a hard time knowing how to differentiate.
I think it's a great point.
Yeah, spinal
Thank you,
headaches
Lorraine.
too.
Yeah, and what we mean by that is not every headache is preeclampsia, of course, but it needs to be evaluated, and it cannot just be dismissed. And it's fine to give a mother, you know, a lot of reasons, like you said, lack of sleep, lack of hydration, you know, other familial stresses, you know, as beautiful and wonderful of an experience, we all know that it's a very stressful experience too for the entire family. It's a disruption. And so there are a lot of reasons to have a headache. Spinal headache, somebody had mentioned. Absolutely. If she got a spinal or an epidural, there's that risk. So you got to go through that tree of evaluation, right? Let's make sure you're getting some rest. Let's make sure you're getting some Tylenol for the headache. Let's alert the care team to say, hey, this mom has no history of headache. I've noticed she's about 130 over 80 and she's got this headache now. Should we think about sending some preeclampsia labs? What do we do if we give her Tylenol and the headache doesn't go away? I think that's where being aware is very important, and coming up with a plan of attack is very important. It's not going to be a one-size-fits-all answer. Are we in a rush to discharge somebody out of the hospital if, hey, right before discharge, she's getting a headache, and what is that? She hasn't had a headache for 2 days or 3 days while she's been in the hospital. So we kind of have to use our judgment to say, what's going on here? We just don't want it to be information that's relayed and then it's lost, right? And nobody is following up on it. So there's that aspect. The postpartum time period is, if you think about it, kind of crazy, right? A mother delivers vaginally and then loses touch with the healthcare system and care providers for 6 weeks. So it's kind of silly that we do this, right? Up until the delivery, between week 36 to the delivery, we're seeing her every week. And then all of a sudden, she falls off a cliff and she's off on her own. And so the reality is, especially those first few days postpartum, it's a time of education. It's a time of support. It's a time of education. Lorraine, you mentioned the family. So important to include the family and say, look, watch out for these things. She's going to be very tired. She's going to be dealing with breastfeeding and sleep and hydration, and maybe she's not even eating properly. But you got to watch out for some of these other issues that may develop, whether it's postpartum depression, postpartum anxiety, postpartum hypertension, you name it, right? So you got to watch for all of those things. And this is where I think the postpartum nursing team especially plays such a crucial role in terms of setting up for success these families that are then being discharged out. And then what do you watch for? Hey, you've done great, but for the first 2 weeks, you've got a pretty high, you still got a risk of preeclampsia developing. And these are the things to watch for. I know there's some educational material, I believe, that's given out to patients, but just kind of walking them through that is very, very important, right? When do you call your provider? When do you come back to the emergency room? When do you get concerned at home if you're having various issues? The postpartum nursing staff really needs to also pay attention to the hypertension, because sometimes we get a little bit more relaxed in the postpartum time period, thinking, oh, they're delivered and their risk is over. It isn't actually. And so when you look at the rates of mortality and morbidity in the US, a large percentage, in fact, I believe the majority is due to postpartum complications, not due to prenatal complications. And that makes sense because we lose these mothers for weeks. So I hope that helps address some of that. Again, it's not a straightforward answer as in one size fits all. You got to look at the clinical situation and address the situation as it demands. But Lorraine, the other comment you made is that we can make a big difference. So and it's important to pay attention because we can. That's why it's worth all this, right? The random amniotic fluid embolism that's going to happen. Well, you can't prevent it, but what you can do is do drills and try to make sure that everybody knows what to do when that utter catastrophe happens. But preeclampsia is often preventable. There's a comment sent in. I have a question about the PC ratio. Is there anything else that can increase the PC ratio, such as if the patient is ruptured or any vaginal discharge? Should these patients have a collection by straight cath? Absolutely. So if a mother has, it's a great question and a very important question. This is the problem with the PC ratio is, if she didn't do a proper wipe, for even if she's intact and not bleeding, but she didn't wipe her urethra adequately, just vaginal discharge has a lot of protein in it. If she's ruptured, it's very hard for her to avoid getting amniotic fluid, avoiding any amniotic fluid landing in the specimen container if she's bleeding. So a straight cath is much better in those circumstances. People have asked me, well, what's the value of a PC ratio versus a timed urine collection? Look, if I'm trying to figure out at she's 25 weeks, does she have preeclampsia or not? Yeah, a PC ratio is fine. If it's well obtained and the PC ratio is 0.5, for example, it's well over that threshold. But what if she didn't obtain it properly, or what if it's 0.29 or something? Well, and we're at such a very early gestational age, and she's got some high blood pressure. This is where me as an MFM puts my hat on, and I say, look, we have time. We're giving her maybe MAG. We're giving her betamethasone. Let's really try to figure this out. Let's not have a spotty test. Let's do a timed urine collection for 12 hours or 24 hours. We've got the time. Let's try to figure this out more definitively. But, if she's coming at 38 weeks in early labor and her blood pressure is 140/90, and you do a urine PC ratio and it's 0.6, you don't need a timed urine collection. Even if her PC ratio is 0.1, you don't need a timed urine collection. She's got gestational hypertension. She needs to get delivered. So the value of the protein assessment varies, and how you get that protein assessment done may vary depending on where you are. And this is where in the pregnancy, and this is where communication with an MFM is often helpful to try and tease this apart, right? So hopefully that answers that question. Are there any other concerns or questions? Otherwise, happy to end it at an hour.
Hi, this is Renee, the A&M for Mom Baby. I just wanted to extend a special thank you for you taking the time and attention to our staff in this important learning opportunity. So I genuinely really appreciate it. Thank you so much. It was great, great presentations, very informative. Made it easy to understand. Yeah, it made it a complex topic very easy to understand. So thank you.
That's very kind of you, and I really appreciate it. And I know my talks sometimes seem like, where the heck am I coming from? But I think rather than just diving into a disease and talking about definitions and what do we do, I think it's very important to have a holistic understanding of what's actually going on. What's going on to the mother's body? What's going on in terms of normal situations and abnormal? Because it helps you stay more astute, more vigilant when something doesn't seem quite right. And you may not be able to put your finger on it, but you guys are experienced clinicians as nurses. You've seen patients. Many of you have probably seen hundreds, if not thousands of patients in your careers. And you know what doesn't quite seem right, and you may not be able to put your finger on it, but you know when to pay attention to that mother, and that's so important. And it's so important that you raise your voices and say something about it, because as physicians, we're running around putting out all kinds of fires, and we're not looking at the holistic picture. So I really want to, and when you look at anything you're studying that's related to healthcare in general, try to understand where does that fit into the bigger piece of wellness? Where does that fit into the bigger piece of care, for that patient and her family? And again, that's really the philosophy I take into all of this. Thank you, Renee. I really appreciate it.
Hello, good
The
morning.
thanks goes to you.
Hello?
Thanks.
Hello, do you hear me?
Yes, we can hear you.
Yes.
Okay, this is Angelica Aquino, postpartum nurse, and we are being trained to take care of magnesium sulfate patients soon. So my question is, at what point, because we're taking care of a stable mother-baby patient, so at what point that the magnesium sulfate patient can be transferred to the mother baby? I mean, how stable, when, at what level of what mag level does she has to be, and when do they have to be transferred to us from labor and delivery safely?
Yeah, great questions. So again, the reality is that there isn't a MAG level. the intent of that comment was to say people sometimes get confused and say, oh, there's a therapeutic range. There isn't a therapeutic range. And again, the point is that if the mother is not showing signs of magnesium toxicity, hypoxia, shortness of breath, heaviness, things like that, and she has good renal function and good urine output, and has blood pressures that are, under control, that to me is a mother who can be transferred. Now, if she's got, obviously active bleeding, or she's got blood pressures that are not under control, or showing signs of magnesium toxicity, I think those issues have to be addressed first before she can be transferred to mother baby. I'm less worried about that, actually, Angelica, than I am about mothers who are already mother baby status and now are developing some possible issues, that shouldn't be ignored, right? So if a mother is postpartum day 2 on mother baby and she has rising blood pressures, that actually needs to be addressed and highlighted to the physician care team, so they can decide what they want to do. Do they do labs? Do they need to, put her on magnesium, etc. So, Lorraine, I don't know if you have a better answer for Angelica. Of course, there are policies, I'm sure, in place that need to be followed.
Okay. Another additional question. So, what do we watch for? I'm talking about aura for a seizure, beside high blood pressure.
Well, of course, if a patient is describing, I have a sudden new onset headache and I'm seeing scotomata, I mean, I think that's what you need to be worried about. Or if she's been eating fine and doing fine, and now all of a sudden she's got, again, postpartum day 2 or something, severe epigastric or right upper quadrant pain, that needs to be, these are the standard severe preeclampsia symptoms that you got to be watching for. Again, these are the things that everyone needs to be educated about and to be vigilant for. And so again, then do labs need to be sent? Do we need to start magnesium? What are her blood pressures when she's having those symptoms? Where it would be very helpful is for the nursing team to go ahead and assess that patient and say, okay, let's get a blood pressure, let's get some vitals. When did your pain start? Let me update the physician about this, but let's have you stay in bed for the time being. Do we need to get an IV back in? Those are all the relevant things to figure out. If those symptoms are developing, let's not blow that off, or let's not say, oh, you've got some, Reglan already on your medication list. It's fine to give it, but we also need to update the care team, right? And say, look, hey, this mom I'm a little bit worried about. She started developing all this severe epigastric pain. Maybe it's heartburn. I've given her some Pepcid, but the reality is I want to know what else I need to do. And I just checked her blood pressure and she's 130/80. So what would you like me to do? I think that's very important rather than just blowing it off, right? So.
Thank you.
Yeah, you're welcome. Lorraine, I don't know if you have specific policies, or if Michelle has worked on that with you guys, about specific policies for when patients are deemed appropriate for going to mother baby or deemed too unstable to remain on mother baby. I think that would be an area that you guys can explore further with mother baby nursing staff.
Yeah, I think we're going to have to develop that as we go forward. Right now, there's a lot of policy reviews going on and updating, especially as we're working with enterprise. So that's a conversation that as we transition over, that's going to have to happen on a daily basis with the whole care team, what's stable, what's not stable, and at what time would you consider maybe sending them back to L&D?
Yes.
Thank you so much for your answer. Thank you.
Yeah, you're welcome. Thank you.
Great questions too.
Okay, well, I hope people are motivated, and I hope people really got valuable information out of this. nothing that I was presenting is, you know, rocket science. I think a lot of this is just about awareness, vigilance, and aggressive treatment. And again, those are the known interventions that will actually lower maternal mortality and morbidity. And you can go home saying, you probably saved somebody's life. And who else in their jobs gets to go home and say that and feel that other than all of us? It's such a privilege, right? So these are things that we can do and stay on top of and really be the advocates for the mothers and their families. So with that, I don't see any other questions. I'm happy to end the session, Lorraine, if we're ready to do so.
Yeah, I think we're ready to do so. And I also, you know, had mentioned to the staff, send me any questions you have so that we can follow up on them. So if any thoughts come to mind, you know, we could always follow up with those questions as well.
Yeah, and it might even work to wait, like after we've had a few patients come to the unit and that the nurses have, you know, had the experience with it in mom baby, and then there might be more questions that start coming out and they just want more, you know, they want another refresher or whatever. And of course we have some people on leave that have missed the classes and will need to be making it up. So again, thank you so much, sir. Genuinely appreciate your time and attention to us. And thanks, Lorraine, for coordinating everything. All right. Take care.
Right.
Thank you.
Okay. Thank you, everyone. Thank you.
Thanks.
And
Have a great day.
And Lorraine, you'll
too.
download the attendance for us, for everybody, so that we know who's attending and give them credit for
Yes.
payroll. Okay, great.
Yes.
Thank you.
So don't hang up anyone yet. I mean, Dr. Pandipati.
Bye. Thank you.
Yeah, they can hang up. It's still, just as long as you do it at the end, then you'll capture all the information, but people can hang up and it's still in the system, so you can get it. I'll hang on to make sure you were able to